weeks in, just intubating people without anyone else around for your own benefit.
Same thing with chest tubes. There are surgical residents always in house. You can always call in the beginning, there's always a senior surgical resident, like just having them there if you need help with chest tubes or even central lines.
Yep.
Like they're there, they're probably already awake. Like they'll be there though. They'll be helpful.
And it's like part of the routine, like they're aware of it.
Yeah. All right. So indications, there's a ton of them. The answer is you're either putting it in because somebody's got a pneumo or they got a hemopneumo. Like they either got blood in their chest or they got air in their chest or they got both. Right? I don't know if you're necessarily gonna ever put it in for like an empyema in the middle of the night. You may do it like during the daytime with with the attending. And then I guess chylothorax exists, but I've never actually seen one. So contraindications are if they don't just need to have a chest tube, if they need to have their chest opened, that's a trauma contraindication. And then the other ones are making sure that they're not like on a ton of anticoagulation where they're going to bleed. Don't put it through an active infection. And if they're a really bad COPD and you can't tell what's a pneumo and what's just a big bulle of their COPD, that's probably another one. The other one is, and you'll see it, it's not infrequent, people have diaphragmatic injuries, whether the diaphragm is high or there's an injury and the stomach sits above the diaphragm because there's no hole. So if you see what looks like a ginormous pneumo or what looks like a significant pleural effusion and the patient is not hypoxic, I would really look with an ultrasound or a CAT scan before I went and poked a needle into that area, because I've seen it go into the spleen, I've seen it go into the stomach, like I've seen chest tubes go in the wrong positions because you didn't identify that there's a problem with the diaphragm. You don't have to give prophylactic antibiotics. You do have to give them a tetanus shot if it's from a trauma. We're really talking about the anatomic, like fifth rib space, like this angle, like the safety area. So basically you want to really go up to like the nipple line, right? Like wherever, unless they're 200 kilograms and the nipples set like down here, in which case don't use the nipples for, but like with a normal person with like a relatively flat chest, like the nipple line should be high enough. In pregnancy, the diaphragm moves higher, so you have to go higher. God help you if you ever have to put a chest tube in a pregnant woman. Like pregnancy and pregnant women are like my least favorite people to take care of. All the way up there, like in the armpit, and just recognize that it is always better to go higher than go too low. Like if you're looking at the rib space and you're like, oh, is this good? Put your finger and go one more higher. Like that's my general recommendation with chest tubes, especially if you're going laterally, is wherever you think you should go, like maybe go up one rib space, right? And remember, we're all so.
You always think you're higher than where you.
And then you look on the X-ray and
when you look at the X-ray,
and you're like right in there.
The bottom of the lung.
Yeah, that's
Because remember, the apex goes like above the.
You think I'm kidding in the axilla? That's actually, I mean, that's truly that's where you should be going. I mean, especially if someone's pregnant. It's all the way up there.
Yeah.
If somebody's laying flat.
And whenever you put it in and you're like, I know I put it in the lung, but the X-ray shows it's below the diaphragm, I'm always like CAT scan.
Yeah.
Like even if I know it's in the lung, it's CAT scan. So what you really want to do is, and again, with any procedure, is all about patient positioning. So the best way to do it is to have the patient like at 30 degrees with the bed up at appropriate heights. So you're not leaning over or something like that, and to have their hand like tucked behind their head to really open up the full axilla. And patients who are intubated or something.
Like 1% of our patients.
Yeah. Sometimes what you can do is you can take, especially if they already have restraints on, you just take the restraint that's on their wrist and pull it up, and you just tie the restraint back to the head of the bed. You can also like tape the wrist, like wrap the tape around the wrist and then pull the wrist up and then tape it to the back part of the bed. Like that also works. And like an awake patient, you just tell them to put their hand behind their head. So basically you want to set up the Pleurovac before you do anything else, verify that you have everything that you need at bedside, and then you can do some procedural sedation, or you can just do it under local. So with a pigtail, I've only used really big guy comfortable with the Wayne unit kit.
We're pretty much only buying the wings, though. We're pretty much only buying the wings, though.
So like Cooper only has these, right?
Well,
No, they have
there's
the other one.
the other one that I hate.
Yeah, I hate
the,
it.
the,
I don't use
the
it.
harpoon.
Yeah, I don't
Right,
use it.
that's-
Yeah.
You can catch fish with it.
Yeah.
Yeah.
It's basically,
Yeah, that was like guaranteed.
We told the
somewhere where-
supervisors to stop
Yeah,
by
stop
those
by.
ones and just buy these
So
ones.
there are-
They're labeled, it says pneumothorax kit.
Yeah.
Do not grab the one that's labeled pneumothorax kit. You grab a
Just say wait.
pigtail.
yeah, and so what you want, like they'll, cause they're like, they come and they'll say pneumo kit,
Yeah.
they're like boxy like this.
Yeah.
That's not the one.
Not the one. That's the one.
It looks like this or it looks like that. Like, it says,
You can see it. It
It says
curls
wait.
like a little
yeah,
pigtail.
it says like
That's
little
what you
pigtail.
want. You want
Like,
that
that's
little
what you want.
pigtail.
There are single ones that come
Not the
in
harpoon.
where
Not
you,
the-
like with these, basically what happens is you go in with the needle and you get air and you draw back and then you thread a wire down through. Yes, it's cellular technique. It's the same technique that you use for everything else. The other ones, there is no air coming back. You just go in and then it comes out and you thread the thing through and then you pull the like wire on the pigtail and it curls it up. Like there's no knowing where you're going. So my problem, and so I trained in the ER and most of my attendings were old school. Like I only placed surgical chest tubes until I started fellowship. And so like with the surgical chest tube, it's more painful, but you know exactly where you're going because your finger tells you where you're going. So with these, this is basically what the kit looks like. So yeah, 4th, 5th intercostal, 2nd intercostal. With these, especially with the pigtails, you can mainly go apical. And if they're really fat, going lateral becomes a really big problem because there's so much tissue that you have to go through before you even get to the ribs, before you even get through the ribs into the pleura. So most of these, like with the pneumo kits, you're probably going to go apically. Like I said, you're going to put the needle in and you pull back and you get air. Once you get air, you can just disconnect. You take your wire, you thread the wire down, you make a nick over the wire just like you would a chest tube, and then they come with a dilator. You dilate in, you pull the dilator out, and then you just put your pigtail catheter over top of your wire after it's been dilated, and then you push it, and it will go in until you got to make sure that all the holes are in the patient. You don't, obviously, if they're fatter, you go in deeper. If they're like little skinny old ladies, like once the last hole goes in, you're pretty much done, right? And then they hook up to your pleurovac, and you suture these in like Roman sandal style. That's how I've always done them. That's how I've always done them.
Are you a fashionista now?
Yeah. Yeah, you've never heard of it? All right. I'll go over it. I got pictures. All right. So yeah, surgical tubes are a little bit different. Really, it's just you need a couple of Kelly clamps or forceps, surgical tube, a knife, and your finger. There's a whole bunch of other things like lidocaine and this and that, which you should use because you should be nice. But that's really the basics of the procedure, or a knife, finger, tube with clamps, and the clamps are important. So there should be gauze and like blah, 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 blah. In general, you don't have to put big, if you're going to put a surgical chest tube in, it doesn't have to be the big tubes. Like you can use the smaller ones. The only real indication to use a big tube is if they have a lot of blood or bleeding, in which case you can clear the blood a little bit better. But it's actually never been proven, and there's some studies out there that show the pigtail catheters are just as good as surgical chest tubes to clear blood and hemothoraxes and things like that. It may be a little bit better with when you're having like pus and like multiple loculated effusions in the chest, but there's really no indication for a surgical tube that makes it superior to a pigtail catheter. So, so what you're gonna do? There's a clamp right there. No, there's a clamp right there. Right. In front of you, what's it not? Probably. I would. Is it in my pocket? Is it in my pocket? No.
I know.
Oh, anyway. All surgical chest tubes come with a trocar. I don't know why. This goes in the trash, right? It's got eyes that you see, and what you do is you take your Kelly clamp and you thread it up through your last eye, and you clamp with the tip of the Kelly just a little bit distal, and then you take another clamp you clamp the back end of it, because whatever's in there, you don't want to come out on your shoe. So make sure you clamp the back end of the chest tube. And so once you clamp the back end, anesthetize the patient, blah, 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 there's where you're going. So you're going to inject. And so you inject into the like subcutaneous tissue, and then you actually inject over the rib exactly in the track that you're going to go. You pull back until you get air where you're going to go, or you get fluid, and then you push your lidocaine in to anesthetize the pleura. That's where you really need to spend the vast majority of your lidocaine, because the pleura is what hurts. Like the subcutaneous tissue doesn't hurt. The pleura is what causes all the pain. So you prep widely, you towel off your area, you make your cut above, like put your finger on the rib, push the skin up, and basically I use the rib as a cutting board. Like use your rib as the cutting board, and that way when you're there, your finger can then so then you're going to insert another pair. So you need 3 Kelly clamps basically. That Kelly clamp goes above and over top of the rib, and as you go in, you're going to open up and expand. So you go in a little bit and you expand out. You go in a little bit and you expand out. Go in a little bit and expand out. Because if you just go straight in, the hole that you're making is only the width of the tip of the Kelly clamp. And that becomes a problem. So like you really, when I say open up, I mean open the thing up and pull back, because the track that you have to create, because once you puncture into the pleura and you open up your Kelly clamp and you're in the pleura, you put your finger in there as a placeholder when you remove the Kelly clamp in, and then you take the chest tube in and you insert it next to your finger so you know exactly where it's going. So the hole that you're making has to be big enough, and the track has to be big enough for your finger plus the chest tube with the Kelly clamp on it. So that's why these hurt, and that's why pigtails are nicer, because you're not creating a 3-inch track in this person's chest.
And if you lose the hole in the pleura, you're never going to find it.
Yeah, that's a true story. That's a depressing but true statement.
You can't find it.
Yeah.
It will never come back.
And so what you do is, like, your finger goes in and you feel the smooth part of the pleura. You insert the chest tube with the Kelly clamp next to it. You undo the Kelly clamp, and then with your finger, you direct where you want the chest tube to go. If it's a pneumo, you direct it up. If it's like a hemopneumo, you can flip it and direct it down, right? So, but your finger directs where it goes. Boom, boom. So you're in with the Kelly clamp. They don't have their fingers as placeholders, so I don't know how they know where they're going. They don't. That's not going to be fun. So that's how you put it into the subcutaneous tissue, and you get a chest X-ray with a tube going up the side of the ribs on the outside of the ribs.
I don't like that, right? Like you have to feel the lung. You have to make sure it's not over there. And like I've seen people do it wrong, or they come to our unit after they did it wrong, and guess what a chest tube is? It's through the lung.
Yeah.
So the point with these surgical tubes,
And you may have adhesions also. You may like have to push the lung.
You can like, you can squeeze around.
You're gonna feel it. You're gonna know the lung.
because like the pleura should be smooth. If it's not smooth, then it's adhesion.
And you can pull back and then feel the ribs. So
Yes.
you should feel ribs, and then you should be able to turn your finger the other way and feel nice smooth pleura.
Yeah. So these tend to go where you want them to go. With the pigtail catheters, it follows the needle and it follows the wire. So I'm really careful with if it's just small enough of a pneumo that needs intervention, or on a big person or something like that, where you're aiming at a smaller balloon with a lot of more adipose tissue or something like that to go through. I get really nervous about pigtails because they're only going to go where the needle goes. And if your target is small and your tissue is deep and you're not as good as like if it was a thin person where you know exactly where you're going, I've seen pigtails go into pulmonary arteries. I've seen pigtails go into hearts. I've seen pigtails go into things like surgical chest tubes can go into fissures and can go into lungs and something like that. But you have to be really dumb because you know where you're feeling. I'm sorry, you know where you're feeling. Like you know where you're feeling, and like you're either in a hurry or you don't know what you're doing. In which case, you shouldn't be doing the procedure. Sorry. So, Roman sandal, just okay?
I was so curious what the sandal was going.
Yeah, so basically you make one loop and then you make another loop around it, almost like you're tying like half of a percutaneous closure around it, and then you tie it off on the front, and then you basically lasso it around the tube, and then you can just throw a hand tie, lasso it around the tube, and then throw a hand tie, but it ends up looking like an old pair of like historic Roman sandals. So
It's the Roman lasso.
The Roman lasso. Then some gauzes come pre-cut, like with the little thing on the top of it. There's also you should use like some sort of like Vaseline gauze, and then put this type of gauze over top of it. And then they come with this really nice tape that I've only ever found in like the surgical chest tube carts or like ortho. It's like the foam, really sticky on one side, and then you like kind of just tape it down the side. You can use other type of tape; it just doesn't look as nice. The main thing is with any of these is that whenever you're connecting the piece into the pleurovac, like there's a connector piece that goes into the tube, I tape both ends of that connector piece. It's like a little, I forget what the valve is called.
Yeah, you have to tape them together. If you don't tape them together, somebody will pull it apart at some point.
Yeah, and then it's not to suction anymore. It's just open to air. EM wrap has how to set up a drain. The nurses tend to do this. We can skip over this for now. Mainly, if you're putting it in for a pneumo, the pneumo should resolve. If the pneumo doesn't resolve, make sure it's actually hooked up to suction. If it still doesn't resolve, it may need a second tube. And if it's got a second tube and it doesn't resolve, it's because there's a communication between your trachea and the pleura, and that's a big problem. If you put it in for like a hemothorax, that's where you have to watch the output. So if it ever starts going too quick, it means it needs surgery. So that's the big thing, and nobody can really agree upon like how much is too much and this and that. In general, as the medical intensivist or the non-surgical intensivist, make sure that you've addressed any medical reasons why they could be bleeding. Like make sure they don't have a coagulopathy. If they want an antiplatelet, if they're uremic, can we give DDAVP? Can we give them platelets? If their INR is too high, can we give them FFP? Things like that. And once we've ruled out medical bleeding, or if it ever starts bleeding too much, it's just a call to the surgeon. Complication is basically you put it in the wrong place, or if you got obstructed. But the main complications are you put it in the wrong place. So also, if you suck out too much too fast, you can get re-expansion edema. You can put it through one of the blood vessels on the outside, which those are arteries. That's why you go above the rib, because those rib arteries can bleed a lot. And if it hits the sternum or the heart and then redirects another way, that's also not good. That's why you got to direct it up or down and not just in. If you put a chest tube in and you start seeing somebody have PVCs or runs a VT, pull it back. I don't care if you know where it is or not. If you put it in and you look at the monitor and they're starting to do something funky, pull it back. That's the answer. Don't even wait for an x-ray to confirm placement. You just pull it back. And then if you put it in the lung.
Which is the most common.
This is the most common.
This is the most common. Of all the other ones are terrifying, but the most common thing is it goes into the lung. And you have someone who, let's say, had a pneumothorax, you put in the pigtail chest tube, and then you notice, oh, that's a lot of air. Not like 3 minutes of air and then it stops. It's just bubbling.
Yeah.
Literally the actual canister will almost bubble so much that it's gonna pop off the floor because it's so turbulent. That is really wrong.
Or you put it below the diaphragm.
Which no one's gonna do this entirely.
No.
Not happening.
No. So really quickly, for these, with the chest tube, it's basically the pleurovac looks complicated. It's not, it's just 3 bottles in one system. So when you put it in, you have your drainage cannulas, and that cannula eventually will hook up, one of them will hook up to some sort of water. And this is the sealant part, right? So if you have it hooked up to nothing, it just drains and it's hooked up to a quote unquote water seal. That's why they say it's placed to water seal versus it's clamped. But if it's placed to water seal, it means you've taken it off of suction and you're just on the seal. If you're suctioning out, what you basically are doing is creating a negative pressure. So pressure is being exerted on the water to help drain, to help put out suction and pressure against the tube. But it can't, when you take it off of suction, it still stays to water seal, because what you don't want to happen is if it comes off a water seal and it's open, you've now opened a closed system and things can go back into the lung. That's why it always stays under, and that's why you have to inject the blue dye or the blue water into the pleurovac system to quote unquote keep it under sealed. And then the suction device just has an open to room air suction down to the pressure that builds up in the bottle. It's really, there's a drainage There's a water seal and there's a pressure, right? If you're not off suction, you must be on water seal. And there's a difference between water seal and clamping the tube. They're very similar. They should result in the same thing. Just people refer to them as clamping the tube versus taking off suction to water seal. That's just basically the common vernacular. So in a Pleurovac system, here is your drainage. Here's bottle number 1. Here's bottle number 2, and here's bottle number 3. Right? They're just all in one vertical system as opposed to being 3 bottles laid out next to each other. That's too much.
The one thing I would say, there's a lot of new nurses who know what bubbling equates to an air leak. Because you will have a nurse walk out of there and tell you, yeah, they have an air leak, and you go and you're like, no, you don't.
So when you put a chest tube in, and it's like when you have a pneumothorax, this is going to be bubbling.
Yeah.
Because you're sucking out, like it's to suction and you're sucking out bubbles. The second that quote unquote pneumo goes away, this doesn't bubble anymore. And how you know if the pneumo's truly gone or not is this is always hooked up to suction on the wall. What you can do is you can just take your finger and pinch the suction, which in quote unquote takes it off of suction and places it on water seal. If there's positive pressure in the chest, it comes running out and it causes your thing to start bubbling again. So if you put something in for a pneumo, it should bubble for a little bit, like Lindsay was saying, and then it should go away. If you put it in the lung where there's constant air going into it, it's going to go right. And when it's all done, you check it the next day by clamping the tube and seeing if the pneumo is fully resolved or if it's coming back a little bit. And if it's fully resolved, when you clamp it, you shouldn't see bubbles. If you clamp it and you still see bubbles, that means the pneumo is not gone. And so generally what I do is I clamp it, I wait like a minute or 2 to see if there's anything there. If the chest x-ray doesn't show anything, there's no bubbling or anything, you can put it to water seal. Or whoever placed the chest tube can put it to water seal. Because the number one thing is, he who places the tube and or instrument owns the tube or instrument. The duration of the thing, right? Like we place the ET tubes. We determine when the ET tube comes out. If anesthesia and surgery intubate the patient and the surgeon wants the patient to stay intubated, you can have a conversation about it, but like there's a reason why he maybe wants it in. If the surgeon places a tube or the surgeon places a line or something like that, or urology places a Foley, he who places it owns it, right? That's how I've worked it. And you can have conversations. You're like, I don't think the patient needs it, blah, 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 blah. And you can have a conversation about it. You can convince them to come to your side of the plate, but ye who places it owns it. Your life will be much easier if you just accept that.
Right? Like you don't want someone going in and like randomly doing stuff to like when you put something in either. So it's really just like common courtesy and all that makes sense. They placed it for a reason. That was for a reason. So I just want to talk to them about it.
So let's split.